Hi, and welcome to the Future of Dermatology podcast. I'm your host, Dr. Faranak Kamangar, board-certified dermatologist. We are here to talk about anything and everything dermatology related. You'll hear from me and my guests who are dermatologists, physicians, experts, scientists, residents, and medical students in the field of dermatology. We publish weekly, so if you like what you hear, hit that subscribe button and show us some love, and thank you for joining us.
I'm so excited for today's talk. We have the most legendary guest on today. I'm going to do a full introduction of her, but I'm so excited for this. I've been waiting for it for some time. I met her a few years ago, actually, while she gave a lecture, and I remember just being awed by the lecture that she gave. So you guys are going to love this episode. So today we have Dr. Natasha Mesinkovska, MD and PhD from UC Irvine. I don't think she needs really much of an introduction within the dermatology group, but I will read some of her many accomplishments. But she is a prolific writer, speaker, researcher. She's a Mayo Clinic and Cleveland Clinic trained dermatologist and dermatopathologist, and she serves as the vice chair of clinical research at UC Irvine. She runs a very busy clinical research unit. She's dedicated to alopecia, aging, inflammatory disorders, and she's the director of the Integrative Dermatology Center as well. She also, what I thought was really cool in her bio, as part of the Laser Institute, she works on non-invasive imaging modalities for skin and hair conditions. And she is just an exceptional educator, mentor. She's received so many awards. She's been the chief scientific officer for the National Alopecia Areata Foundation. She serves on the board of directors of American Hair Research Society. And she's just such an asset to our field. But on top of that, she is just a really, really cool person. So I'm so excited to have this conversation. Dr. Natasha, thanks so much for joining us.
Thanks so much for having me, Farah. You're reading that and I'm like, whoa, that's like 3 lifetimes. No wonder I'm tired.
No wonder. Yeah, no, you are so fantastic. And there's so much. I know we keep these episodes on the shorter side so that people, their attention spans can stand it. But there's so many aspects that I want to ask you. Of course, all the hair research you do, and you're always educating. I learned so much from your lectures, and I go back to clinic and I make actual changes. So thank you so much for always educating, and hopefully we'll get to some of that as well. But I would just love to even start out with just you and your journey, however much you want to share with us, because you're just such an amazing educator, person. You're always just so energetic, so positive. And I think, that in an era where many doctors might be a little burnt out, or there's some negative talk, it's just so refreshing. It's a little bit, it's so refreshing to have someone like you who's like, no, our field is awesome. And, these are the amazing things we could do to help patients. So we'd just love to hear about your background.
For sure. People are going to hear the accent, and I do talk funny. And even when I talk with my people, they're like, you really talk funny. So I was born in former Yugoslavia overseas, and I came over here when I was 15 as a high school exchange student, and then I stayed. A lot of good people helped me. We always joke it was like the Natasha foster system, but my dream was always to change the world, make medications, kind of like that pageantly response, I don't know, no diseases. So I really wanted to be a doctor forever and ever. And that's the dream. And I feel like no matter what we say, we live in this country that really allows anyone, if to do things that they set their mind to. So I feel like I'm still like this living testament of the American dream, that you work a lot, you get stuff done, and you move on up. I mean, it's not an easy thing, but I feel like I owe a lot to people that helped me, to the institutions that taught me and raised me. So my whole life right now, it's, patients, mentees, trying to just kind of grow the future. That's the name, the Future of Dermatology, like your podcast.
Yeah, actually, I think you embody what we try to do with this podcast, which is creating that just positive environment where our mentees, residents, even fellow colleagues, because sometimes in a long career, you can have moments of ebbs and flows of kind of how you're feeling about the choices you made and what you're doing. So I think just that what you explained there is what we're trying to do, is just bring it back to It's really amazing work. There's a lot of challenges to being a physician in healthcare right now. But at the end of the day, it's still a really, really great field that we're in. And like you mentioned, like the institutions that trained us and the people that trained us, and like we're standing on the shoulders of giants. So I always share that too. So I think we share a lot of that mission.
I mentor a lot of medical students still. And when I look at the kids that go into medicine, oh my God, I'm saying kids, I'm grown up now.
They seem really young, don't they? When they come to clinic,
I just love them, man. I love them. I really love every single one. But the decision for everybody is like, you don't go into this for the money. We all know it. And I think many of us, 10 years in, like where I am or more than that, you kind of feel like, what do you want to do? Do you want to see patients? Do you want to do research? Do you want to do consulting? And I think the beauty of AI and everything that's coming in and quote unquote, when people say replace us, please may it replace us, may it help us, like, diagnose things better. So then we can, in a way, take a direction that we want to. Like, I love seeing patients, but that exhausts me. So I like doing research, but that can be a lot, because for everything you publish or every grant you get, there's like 10 that don't get published. Nobody sees that. I like giving talks, but that gets exhausting. So really trying to balance it. I don't know. I don't think it's a balancing act anymore, but I am excited of future dermatology. I'm excited of, the options and the opportunities that we all have. Like, I know going into derm personally, I thought, because I was debating between hemonc, I thought it was going to be probably like a T-cell lymphoma person. I thought maybe that's what most MD PhDs, but then enters my mentor, Wilma Berkfeld, the first, I think, female president of the AAD. She formed the Women's Derm Society, and she was an alopecia expert. And I was so broke back in the day, so she would give me these opportunities, and I would do anything. I'd be like, $100 grant, summer essay in economics. I'll do it, just like because I'm solo here, right? I don't have family, so I had to get whatever I can. But I got into hair that way. But I never, even during residency, that was definitely not my forte. So it's very interesting how in life chooses you, how the path chooses you. And although I see a lot of hair, that's not all I'm about. But that's when people see me, that's what they identify me with.
That's what they think.
Yeah, which is cool. It's cool. I rock extensions. I bleach my hair. Yeah. I straighten my curls. I do everything that I can to, in a way, embody that and allow the perceptions. People will be like, why do you have a clip-in extension? Or why do you talk to people about hair? I'm like, because when we talk about some of the stuff for our patients who don't have hair, we, in a way, have to allow them to know that that's what, the celebrities do, the Instagram people do, and that's what people do. So I feel like, I don't know, it's kind of fun part of being the provider.
Absolutely. And you're kind of embodying that, it's not that all these celebrities have this crazy long hair naturally and this and that, and you're just not doing the right things, because everybody comes to our clinic and they're trying to live the dream of a certain look. And that's the aesthetic part of dermatology, which I think is so interesting, because you have the dermatologists, and a lot of us are coming in with this background of immunology, science, immunotherapies, and this is what's going on in our brain. But then the person walking in is coming in with all the social and everything they're seeing. So dermatology is a really interesting field, I think, in that it's kind of hard to interface those two things, because you see someone with alopecia areata coming in our brain, we're thinking okay, the pathway, mechanism, what medication we're going to try, and they might be coming in with a totally different, view of it. So it's a hard one. I think that might be why some dermatologists shy away from hair. It is challenging. I think it's it's not as easy as maybe some of the things we do. So
I would tell you, one of the most refreshing things is seeing young residents now want to do hair. There's a whole slew of every nationality now. I think it's the thing to do. We're owning more hair. We're owning more kind of genital dermatology, all this stuff is really hot, and things that were underexplored. And I think a lot of the fear from hair we had, Farah, was we didn't have options. We didn't have treatments. And now we do. And I'm not talking just about the JAK inhibitors, which really are kind of revolutionizing, not just alopecia areata, not just scarring alopecia, but atopic derm, neutrophilic dermatosis, everything that we have in dermatology that really we didn't have good answers for. JAK inhibitors have provided such a good option, and taking a pill that's short lasting, kind of we feel a little bit more comfortable with it. But then just like minoxidil, oral minoxidil, is really kind of taken a whim. And I remember before COVID, like 2019 or something, when we wrote this little article, got shoved somewhere trying to tell people about it. And then it kind of caught wave. So it's good. I'm excited that there are options. And I think people are more open now to treating because there are options. I think one narrative that we have not pushed as derms when it comes to hair, we can say hair is just hair, but it is not, because it is part of the appearance. And I think a lot of the derms and the problems we have maybe with our other medical colleagues is, we are the biggest system. We are. So as we age, that whole process of inflammaging that biohackers love to talk about, when we look at the blood biomarkers, the biggest inflammation biomarkers come from where? From skin, simply because of the size that we have. So the changes of the skin, hair being an appendage is part of it, as we are not 20 anymore, are something that manifests. And you can attest to what I say, like when something's on the skin, it takes forever for people to kind of get accustomed to the thing that is going to change. You can't see your hemoglobin A1C on the daily. You cannot see your cholesterol on the daily, but you can definitely see your skin and you can see your hair. So there's definitely this burden that we can't ignore.
Yeah, that's a really great point. I think we interface with a lot of the things that people are seeing that's happening to their body, and they're psychologically grappling. Well, okay, I'm aging. What does that mean? And the whole longevity field right now, I think, is just a marker of that. It's kind of like the old. It's hot. It's like the old fountain of youth that people have been chasing forever, right? But now it's people in the past were like, it's never going to be possible. But now there's conferences where they're like, no, it's possible to do things where you never die, which is no, I don't think that's possible. But, they're really going for, let's push the limits of nobody ages and let's take medicines and all this kind of stuff, which I'm for part of that too, for sure. But then some of it, I'm like, okay, that's just kind of more for Instagram. That's not a realistic thing to do, but it's true. I think as dermatologists, we face so much of that. Like the first thing a patient sees, they come to us. Right, as opposed to they're not going to see their sugars necessarily unless they're on a glucose monitor, which everyone is getting on now as well. But it's so true.
Yeah, I agree with you. And I think there's nothing wrong with looking the way you feel.
Yeah.
There's nothing wrong with, there were such things and thoughts that women over a certain age get dismissed. And think about men at the boardroom, I live in Orange County, so you have to do cosmetics. So you can all judge me being MD, PhD, derm path, but I work for university. I got to raise my RVUs, and I actually have pretty good hands. So that's the secret. That's my secret sauce. It's my pretty good hands. But the thing is that, everybody as we grow up, we do get judged. So, having some help with some of those things helps every single one of us. When it comes to hair, I think one concept we don't talk about enough in the books yet, but it's going to make it. There is this whole concept of senescent alopecia or aging alopecia, right? And I always try to teach everybody, and I try to say to patient, it's okay for you to get wrinkles. It's okay for you to sag. Why is it not okay for the hair to be thinner and to be grayer? And gray hair is definitely not normal hair. Not the hair that people are used to. So that's one of these things that we have to learn more about, what's the anti-aging for the scalp? What's the anti-aging for hair? Because part of aging of hair is really scalp inflammation, this kind of microinflammation that happens. And that's what we see on histology, and things that can be addressed little by little as we're learning more.
I love to hear you. What do you think about the trials with FFA, or the studies with FFA finding chemicals in the hair roots and the chemical sunscreens? What's your kind of thought about that? We've had other speakers that really just even will tell their alopecia patients, for frontal fibrosing scarring alopecia patients, maybe stop their chemical sunscreens or be careful with cosmeceuticals. Is there any specific guidance that you give your patients in clinic?
So FFA, frontal fibrosing alopecia, I say is the bane of our existence. Supposedly didn't exist around a lot since before the 90s. So when I used to go to these meetings early on, and all the big wigs will say, like, we're going back through our Kodachrome image collection, and we didn't really have it. That's so interesting to kind of hear big people in alopecia and hair talk about how they really did not see this condition that often. And I can't ignore that study that came out of, and it was from the UK, showing that daily use of sunscreen, particularly men, you're thinking, like, really, do people use a lot of sunscreen? And I don't know, like, year round, that was a factor. And then there was a case report from Australia by Dr. Sinclair, Rodney Sinclair, who's an alopecia guru when it comes to Australia for sure, where he actually reversed some of the early FFA changes by stopping using a chemical sunscreen. So what I do and what I say to patients now is I try to only use zinc sunscreen, and we try to avoid the hairline. But that being said, I just applied cover up that has titanium in it, because some studies also have shown titanium. And I'm like, tomorrow probably something's going to come out even against zinc. Is it or isn't it? I don't know. But the chemical ones, I do try to, I guess for now, stay away. Does that explain everything? Absolutely not, because people not only have that frontal alopecia, which is such a misnomer as you and I know, because it kind of wraps around. It can even go in the middle, right? There's these patterns. But a lot of people lose their arm hair and their leg hair. So how does that come into play? About a third of patients will have thyroid abnormalities. So how do these antibodies come into play? It's much more than that. But we do see that a lot of these patients have contact dermatitis, have sensitivities to fragrances and topical components. So we try to figure out with my patients, what are you sensitive to? Sometimes I even send them for patch testing. I don't do it, but just depending on what the history is. But yeah, maybe I'm a bad dermatologist, but I say put hats and avoid the hairline. And there's plenty of mineral sunscreens now that don't make us look like a tennis player. So long-winded answer, but yeah, I still do. What do you do?
Answer.
Do you tell them?
I think everyone is. I'm still confused too. And some of my patients, if we're having trouble clearing them, I might just say, well, maybe just, stop, these certain ingredients. But like you mentioned, it's hard to know because there's so many confounding factors, and then the trials are not super consistent. But again, like, we do have good options now with zinc that is not terrible. It's not going to give you that giant white paste. So maybe just kind of switching over. And then I think there is that trend starting with scalp care as skincare. And there's different lines coming out and shampoos and different things around it. And of course, anytime there's some skincare market to be made, it's gonna kind of flourish. But do you have any specific things you recommend? I mean, we do a lot of PRP in our office, and I think that is to some extent kind of rejuvenating the scalp as well. But like at home, in between PRP treatments and things like that, do you recommend anything specifically? Not to go down like the product recommendation route, but is there anything you recommend now for or maybe even not even necessarily recommendations, but like, how often to wash your hair to get the scalp? And what's your kind of general guidance around the scalp health portion, which, like you mentioned, it's been ignored forever.
Ignored. And how many times do your patients ask you, like, oh, do you have a recommendation for shampoo and a conditioner?
Yeah.
And do you? Because I
really don't. Yeah, I really don't. I think one time I had like a really fabulous patient, and I said to her, like, maybe use like, I don't know, I said something generic, like a Dove or something, like not to call out Dove. She looked like she was like, oh, like I'm never coming back to see you. She was like, oh, like, how dare you?
There's nothing wrong with Dove.
Nothing wrong. Actually, that's a good, not throwing shade at Dove, but it was like too simple for her. Like she wanted me to say some like, I don't even know, some version
fancy
of something
stuff,
fancy, something fancy. Yeah, exactly.
No, but I was, even myself, like when patients will ask me, like, what do you use? I'm like, I'm in between hotel shampoo samples or whatever, like, because I'm always on the road. I feel like on weekends, and then during the week it's patients. And, I had to learn a lot more than I ever wanted to. So for the past couple of years, I was part of an advisory board with, like L'Oreal, just trying behind the scenes, not really, I'm not going to say any names or anything, but trying to design something that is going to have like niacinamide, HA, and is going to be like allergen-free, MIT-free, fragrance-free, as much as you can. Oh my God, can I tell you what those things look like? There's such a reason for all these preservatives being in there and for fragrances being in there. Otherwise, things are dull, they precipitate, like they separate, they go bad. Like that's like, they turn moldy or whatever. So there is a reason for why all these things are put in there, but there is something now in the market for people that have sensitive scalps. But we're learning the scalp we tend to strip it, right? Because we like that clean feeling. We like that foam and everything, but that can strip the scalp pretty not nicely. So we're learning more about the oils that have to go in. Ceramides, kind of like the rest of the skin, but how do you get it in between the hair without overgrowing that malassezia? So that's the problem. The more hair we have, the more humid it becomes, the more yeasty it becomes. So how do you get this balance of hydrating, feeding without feeding some of the commensals that live on us?
Yeah, actually, it's a complicated microenvironment when you think about it in that way. I mean, we're like treating people all day, but I don't think we actually take the time to think about it on that like molecular level. There's a lot going on on the scalp.
I like the anti-yeasty thing though. Yeah, I like an anti-dandruff shampoo at least once a week, once every 2 weeks, once a month. I say summertime when you're sweaty or whatever. If you're a person that goes to the gym and goes
just
to sauna,
do it. Leave it for a few minutes. Yeah,
like a minute or two. Anything like selenium, ketoconazole, whatever your choice is, zinc.
Just do it every once in a while.
Once or twice a month, just to kind of cleanse the scalp, especially as your hair is getting thicker and better. I think that's not a bad idea. I do like conditioners to be off the scalp just because I don't know what they're trapping. A lot of them do have a lot of silicones, but one thing at a time. We're learning more as derms. It's a big field. We have to know everything, right? So
yeah, we have to know everything. Yeah, and I think there's going to be so much more coming on in the hair world. And so since we have an alopecia areata expert, I can't let you go without like a few minutes of rapid fire questions.
All right, go ahead.
So because there's a lot of always, a lot of our residents and even early career docs, actually, and myself included, not so early anymore. We're always just when someone walks into the clinic, should we be doing something differently? That's always the question. So I might throw out just some age group and random scenarios. You let me know kind of how you approach it. So
sure.
Let's say the young kiddo now, let's say like a 12-year-old, for example, comes in, maybe a few patches. So not like a small area of alopecia areata, but they're starting to get a few patches of alopecia areata. And the mom's like, oh, it's so bad in school. And what's your go-to, what's your stepwise fashion of how you'd approach that?
Yeah, for kids. About 6, depends on the data, but I think it's more than half of kids will have atopic dermatitis. I think in a lot of kids, alopecia areata is part of the atopic march. So my number one thing is to sit down will be stare at them, check out for allergic shiners, if they're sniffling, if they're raspy, if they're that atopy kid. And then I'll ask eczema, asthma, because I feel like controlling that, even if it's fexofenadine, cetirizine, addressing allergies, doing food panel or something, will help me control this versus me just poking the head and doing ILK or putting people on a JAK inhibitor if there is a reason. Right, so that'll be the first thing. So first thing I always say is, particularly in kids and adolescents, somehow that trend disappears and it turns more autoimmune in adults. This is my observation, guys, so I don't want anybody to be super mad at me if all this changes one day. But this is my one thing. Look for atopy in young people with alopecia. The average age for alopecia areata is 30, so most of the people actually skew towards younger. So there's still this chance to not fix it, but to catch what the reason is. And I always teach the parents, if the kid, for example, has eczema and alopecia areata, treat the hand eczema, treat the eczema so we don't lose hair. It's almost like a prevention model. That's my opinion. So for example, kid has eczema. I will talk about doing either topical injections. I don't like to torture people if they don't want to, but I will put them on oral minoxidil, very low dose. Yes, kids, every other day. You can do half a pill if you want to, depends on their size. You can do every day. You can do anywhere from 1.25 to 2.5 milligrams, depending on how big they are. Don't be scared. You can always tell people to just start once a week and then increase little by little as they feel. Topical, of course, minoxidil if they're not sensitive. And then if they're rapidly progressing. So when you touch a scalp that's losing hair, run your put gloves on if you don't like the feeling of hair, because nobody likes hair, I feel. But run your fingers around the edges of that patch, because if hair is falling out, not even a true pull test, right? If the hair is falling out, that means it's active, right? So if people are active, that means they're progressing. So if they're progressing, if somebody has, for example, atopy, I would talk dupilumab or ritlecitinib. If they don't, then probably ritlecitinib. I'm just introducing the concept in case they progress. Otherwise, oral minoxidil for sure, and then topical if they don't, and addressing comorbidities. That's
super helpful. No, that's such a great point with the atopy. And then when do you? So a lot of patients will ask, like, when you're starting minoxidil, how long do I have to stay on this? Like, how do you kind of approach that with the kiddos? Is it like you'll go till hair grows back and then just kind of slowly come off of it?
Yeah, I always say it sucks because we like weaning on then weaning off. We don't go cold turkey. I try not to. But all those studies that say you cannot stop it were made for AGA patients. Now, I'm going to tell you that minoxidil does keep a lot of hair afloat that's not going to be there. So most people are going to be a little bit thicker on minoxidil than off. So even you as a quote unquote full set of hair, you take minoxidil, you're going to grow more hair. Everywhere too, but
yeah,
you know what I mean? Like,
I'm Persian.
So,
it's gonna be a whole thing. I thought about going on it a few years ago and I was like, let's not mess with that.
Yeah, I mean, 80 people are like, am I going to grow hair? So, okay, this is for the whole audience. If people are like, am I going to grow hair? You just go ahead and you say yes. Because 86% of people are going to grow hair elsewhere. You cannot argue with 80% and above. So this way you tell them, and people are going to be like, what do I grow? Some people grow peach fuzz. Some will grow those extra hairs. If they're blonde and not hairy, of course they're going to do better than if they're like my part of the world and like Mediterranean. We have hair, but at least you get people know. A lot of people nowadays have lasered anyways. So, but it's a thing.
Yeah,
it is a thing.
Absolutely. And then when, or I said, what subset of kiddos do you start thinking about the JAK inhibitors? Is it pretty much like maybe after a few months of following and then you're noticing progression? Or do you start thinking about it early on?
I bring if I think there's like it's affecting the kid. So you can have 10% hair loss, but it's right here. That kid's not going to be going to school. That kid's going to be wearing hats, and we forget how hard it is to be a kid. I mean, it's hard to be adult.
Yeah, it's true.
It's not easy. So I introduce it as early as I can.
Perfect.
I introduce it as early as I can. So I don't make people suffer. I put people on minoxidil. But if I think we're going to go there, I start getting the paperwork ready already.
Yeah, just to get everything set up. Because access could be a whole thing as well. And then so now say like that same scenario, but maybe a 30-year-old patient that comes, 30-year-old female comes in, few new patches. What's your kind of general first line, what you do?
Because she's childbearing age, I will also assess for comorbidities, etc. But with adults, we have so many options now, so we can discuss. But because she's of childbearing age, I will find out, like, I'll get in her business. Like, we're getting married. What are we doing? We're getting pregnant. What are you guys planning? Because I cannot start on something, then I have to stop it. Because the heartbreak of getting hair going and then stopping it is a real heartbreak. So what I will see is for her, I will definitely do injections plus minus minoxidil if she's not trying to get pregnant within the next year. I will definitely encourage topical minoxidil. You would think I'm more aggressive with kids than with adults in a way, but with injections still do so well. Like Kenalog 5 in the spots, and then I'll take 2.5 and kind of sprinkle it all around. That's what I do with her if she's not. Yeah, go ahead.
Yeah, do you do any of the low dose pulse dosing of prednisone and dexamethasone or any of that?
So Dr. Britt Craiglow does a lot of this, and a lot of like in Japan. I know that when we go to the World Congress, a lot of people do it. I haven't had great successes the few times I've tried getting people off of these things. And maybe the one time I tried, I don't know if it was all attributable to that or to the JAK inhibitor. So I'm definitely not the person to talk. But Dr. Britt Craiglow, who probably has treated the most kids with alopecia in the world when it comes to systemics, she does use it. She uses pretty strong doses. So I think we need to have her on the show to teach us all about it. Because every time she talks about these doses, I'm like, oh my God. Because I had to be on steroid once, 80 milligrams for one day. And I was like, all right, this is certifiable.
There's side effects. I'm like, prednisone is real. The side effects of it are for sure real. Especially, I totally agree with you. That's the whole thing. It's like, well, how long do we have to keep you on this? So, but
she's very successful, and she has a very good, in a way, reassuring process for the peds derm. So I would definitely reach out to her for anybody that's thinking of using that.
At least that sounds good. Well, thank you so much for that. I just said, look, I can't let you leave without a rapid fire, like what's
Thank
new
you.
in the alopecia areata world. And then we always ask at the end of our session, kind of what are you excited about in the future of dermatology? And it could be anything, like things we talked about, mentorship for women in the future, hair world, I mean, anything at all.
I know this is probably dull, but I really am excited about like the technologies that are coming through. From AI to help people with spots from home. A lot of stuff is in your backyard from Palo Alto to help the histology things. And then all the non-invasive imaging. That's like my baby, my passion are non-invasive imaging modalities. So we don't have to biopsy people if we don't have to diagnose things, even to perform safer procedures. Some of the new medications that are out there. I was recently at a kind of like a Shark Tank Octane here for medications, and just medications that are coming in injections for skin cancers, just like 2 or 3 injections. Most colleagues, you're going to have jobs for a long time, but still, it was just exciting to see all the new technologies and new medications that are coming. And that's it. We're smart field, and I just want us to keep growing and be as good as we are.
Yeah, there's so many great things. There's so many great things coming out. It's a really, really great time to be a dermatologist, I think. So, well, thank you so much. I know you're probably getting prepped for all your talks at the AED next week and flying out. So thank you for taking the time.
See you there. It's the event
and I'll
of the
see
year.
you there. The event of the year.
Right.
The AED is always so much fun. So it was so great seeing you. Thank you for joining us.
Listen, thank you so much for having this and for taking the extra time in your life to do these podcasts and to teach everybody and to, give us something to look forward to. I appreciate you.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.